Bismillahirrahmanirrahim. Today's our topic of discussion is antihypertensive drugs, and we will continue. Tomorrow we will discuss the rest of the antihypertensive drugs. Yesterday we have discussed diuretics, the role of diuretics as antihypertensive. So we will continue this part 2 of antihypertensive. The drug in this case, the drugs are ACE inhibitors. ACE mean angiotensin converting enzyme inhibitors. First of all, I will tell you, in our body there is angiotensinogen, that is basically plasma alpha 2 globulin. On this angiotensinogen, renin act, which is secreted from macula densa. If there is low macula densa sodium and chloride, if there is low glomerular efferent pressure, and if there is enhanced sympathetic activity, then renin is secreted, and this renin act on angiotensinogen. This causes breakdown of angiotensinogen to angiotensin 1. On angiotensin 1, and converting enzyme acts and break down it into angiotensin 2, and this angiotensin 2 is responsible for vasoconstriction. Here I will take the laser pointer so that you can understand. This angiotensin 2 is responsible for vasoconstriction. As you know, this vasoconstriction will cause rise in blood pressure. Moreover, angiotensin 2 also causes sodium and water retention by secretion of adrenal aldosterone from adrenal cortex, and this aldosterone causes sodium and water retention that will increase the blood volume. So increased blood volume and will cause the rise in the blood pressure. I mean to say that when there is low macula densa sodium and chloride, it may be lost due to any reason, for example, due to diarrhea, excessive sweating, or any other reason, due to which the macula densa experiences there is less sodium and chloride. This will give message for the secretion of renin. This renin causes breakdown of angiotensinogen to angiotensin 1, and angiotensin 1 is broken down to angiotensin 2 by the converting enzyme. And this angiotensin 2 is a powerful vasoconstrictor. This will cause rise in blood pressure. Moreover, this angiotensin 2 causes secretion of aldosterone from the adrenal cortex. This aldosterone causes sodium and water retention. This will also increase the blood volume. So, body has attempted to maintain the blood pressure. This is normally occurring in our body. I have told you that our kidneys are concerned with a major role in control of our blood pressure. So it means that you can see here a big red color cross. If we use renin inhibitors, angiotensinogen will not be broken down into angiotensin 1. If we use a drug which block this converting enzyme, these drugs are called ACE inhibitors. The drugs that block this converting enzyme are called ACE inhibitors. If we use these ACE inhibitors, angiotensin will not be broken down into angiotensin 2. So there will be no vasoconstriction, no aldosterone secretion, no salt and water retention, no increase in the blood volume. It means that we can use converting enzyme inhibitors to decrease the blood pressure. We can use renin inhibitors to decrease the blood pressure. So this was the normal physiology that is going on in our. Again, you can see here. Here is angiotensinogen 1. On it, renin act and convert it into angiotensin 1. On angiotensin 1, converting enzyme acts and convert it into angiotensin 2. This angiotensin 2 causes vasoconstriction, aldosterone secretion, and finally increase in blood pressure. If we use ACE inhibitors at this level, there will be no angiotensin 2 and there will be no increase in blood pressure. So you can see here ACE inhibitor. Now let's see. This ACE is also responsible for a second pathway. And what is this? Here is the kininogen. This kininogen is broken down into bradykinin. This bradykinin, with the help of ACE, is broken down into inactive metabolites. If we use ACE inhibitors, there will be no breakdown of bradykinin. There will be more bradykinin. And what does this bradykinin do? Bradykinin do increase prostaglandin synthesis, and you know these prostaglandins are powerful vasodilators, so there will be decreased peripheral vascular resistance and decreased blood pressure. So students, see here, if you are using ACE inhibitors, so there your blood pressure, the patient's blood pressure will decrease by two mechanisms. One is by no breakdown of angiotensin 1 into angiotensin 2. This is the first mechanism. There will be no angiotensin 2, no increase in blood pressure. Number 2, ACE will inhibit the breakdown of bradykinin. Bradykinin will accumulate and it will cause vasodilation, decrease peripheral vascular resistance and decrease blood pressure. So by two pathways, the ACE are responsible for decreasing the blood pressure. So whenever you ask, write down mechanism of action of ACE inhibitors, you will always write down not only this angiotensin 2 but also the bradykinin, which is responsible for vasodilation and decrease in blood pressure. Then your answer will complete. Renin, angiotensin and aldosterone play important role in some people with essential hypertension. There is a study that in some people, in about 20% of the people, have high renin activity and some have low renin activity. The patients who have high renin activity and are hypertensive, these patients will respond very well to renin inhibitors or to ACE inhibitors. Similarly, this angiotensin generation is not only is present in your kidneys, it is also present in your heart. And in heart, this angiotensin is responsible for many trophic changes, such as cardiac hypertrophy. So when you use these ACE inhibitors, it also prevents these trophic changes and these cardiac hypertrophy. So these ACE inhibitors are very beneficial in the patients in which there is cardiac hypertrophy, so their hypertension will be controlled as well and there will be also less trophic change. So ACE inhibitors are recommended as first line treatment of hypertension in patients of high coronary disease risk, are patient of diabetes, stroke, heart failure, myocardial infarction or chronic kidney disease. These are the patients in which ACE inhibitors are recommended as first line treatment. Now I will tell you why we use these ACE inhibitors in diabetes or stroke or heart failure as we proceed. I have told you the second pathway that the ACE is responsible, that is of bradykinin, and this bradykinin increases the production of nitric oxide and prostacyclin. The prostacyclin is a prostaglandin, and the nitric oxide and the prostacyclin, they are vasodilators, so they will decrease the peripheral vascular resistance. As a result, there will decrease in blood pressure. I have told you that the blood pressure is equal to cardiac output multiplied by peripheral vascular resistance. Any component if decrease, there will be decrease in the blood pressure. ACE inhibitor decrease the angiotensin 2 and increase the bradykinin levels. Now is the mechanism. How they decrease the blood pressure. They decrease angiotensin 2 and increase bradykinin levels. Vasodilation is the result of decreased vasoconstriction and enhanced vasodilation from the increased bradykinin. By reducing the circulating angiotensin 2 level, ACE inhibitors also decrease the secretion of aldosterone. And I have told you that this aldosterone causes what? This causes salt and water retention. So there will be decrease in the blood volume and the decrease blood pressure. ACE inhibitors in this way reduce both the cardiac preload because they are decreasing the blood volume, and they are decreasing the afterload and a cardiac work because they are decreasing the peripheral vascular resistance by these increasing the level of bradykinin. Because bradykinin increases the prostacyclin and nitric oxide, they are powerful vasodilators. They will decrease the peripheral vascular resistance, so afterload will be increased. They decrease the blood volume, so preload is decreased. They decrease the peripheral vascular resistance, so afterload is decreased. So ACE inhibitor reduce both preload and afterload, and therefore they decrease the cardiac work. And when they decrease in the cardiac work, there will be decrease in the blood pressure. Now are the adverse effects. ACE inhibitors, there is usually fall in the blood pressure with first dose, especially in the patients who are taking diuretic, are the patients who are chronic heart failure patients. In these patients, there is risk that the patient may experience fall in blood pressure with first dose. Moreover, ACE inhibitor causes hyperkalemia because of aldosterone. Because aldosterone, there is sodium and water loss, and there will be preservation of the potassium that will lead to hyperkalemia. Cough is due to increased bradykinin production in the lungs. This will cause dry cough, and this is very major side effect with these ACE inhibitors. Dry cough is the major side effect, and it is due to the accumulation of bradykinin in the lungs. Similarly, patient may experience rashes and urticaria, and patient may experience angioedema. This is also due to bradykinin. Patient may experience dysgeusia or parageusia. It is fetopathic. It is contraindicated in the pregnancy because it causes fetal malformations. It can cause malformations of the kidney in the fetus. Patient may experience headache, dizziness, nausea, and bowel upset, granulocytopenia, and rare proteinuria. Patient may go into acute renal failure. What are the advantages of ACE inhibitors? They are free of postural hypotension, electrolyte disturbances, feeling of weakness, or CNS effects. They are safe in asthmatics, diabetics, and peripheral vascular disease patients. Long-term ACE inhibitor therapy has the potential to reduce the incidence of type 2 diabetes in higher risk subjects. That's why we use ACE inhibitors in diabetes. I have told you that it is a first line treatment in patients with diabetes. Here is the reason. Because they reduce the incidence of type 2 diabetes in high risk subjects. And if a patient is diabetic, then they prevent the diabetic nephropathy. In both situations. In prevention of diabetes, also if the patient is diabetic, then they prevent diabetic nephropathy. Therefore, we use ACE inhibitors in patients of diabetic nephropathy. Their blood pressure will decrease. Also, they will be prevented of diabetic nephropathy. With ACE inhibitors, there is no rebound hypertension and withdrawal. There is no hyperuricemia or deleterious effect on plasma lipid profile. ACE inhibitors are the most effective drugs for preventing sudden cardiac death in post-infarction patients. However, they are less effective for primary prophylaxis of myocardial infarction or preventing left ventricular hypertrophy. This has been derived from studies. However, ACE inhibitors are most effective drugs for prevention of sudden cardiac death in post-infarction patients. Now come the uses. Obviously, these are antihypertensive drugs, so we use it in hypertension, first line drug in all grades of hypertension. But ARBs have now surpassed them in popularity. ARBs are the angiotensin receptor blockers. We will discuss in next slides. Essential hypertension respond to monotherapy with ACE inhibitors, and majority of the rest do their combination with diuretics or beta blockers. Number 2, use of ACE inhibitors in congestive heart failure. Because ACE inhibitor causes, we have discussed, arteriolar and venodilation. We have discussed that there is a accumulation of bradykinin, and the bradykinin produces prostacyclin and nitric oxide, and both of these are vasodilators. So this vasodilator will decrease the peripheral vascular resistance. They will cause both arteriolar and venodilation. So they will decrease both preload and afterload. That is the reason why we use ACE inhibitor as a first line treatment in patients who are hypertensive and also patients of congestive heart failure. So if you are asked question why you prefer ACE inhibitors in congestive heart failure patient as a first line treatment, your answer will be that ACE inhibitor decrease the preload and afterload. So we use these drugs in congestive heart failure. And the next question will be from you, why they decrease preload and afterload. You will tell that they cause vasodilation. How they cause vasodilation? Because they cause accumulation of the bradykinin, and bradykinin will lead to production of prostacyclin and nitric oxide, and both of these are vasodilators. So where they will decrease the peripheral vascular resistance, there will be both arteriolar and venodilation, and that will lead to decrease in afterload and preload. This is very important, and it is oftenly asked in your viva question as well as in your SEQs. Why we use there in myocardial infarction? I have told you that there is a study that long-term use of inhibitor reduces the recurrent myocardial infarction. Moreover, there is decrease in sudden death rate in post myocardial infarction patients if you use ACE inhibitors. Prophylaxis in high cardiovascular risk patients, because they are responsible for ACE inhibitors may improve endothelial diabetic nephropathy. Prolonged ACE inhibitor therapy has been found to prevent a delay and stage renal disease in both type 1 and type 2 diabetes. I have already told you why we use ACE inhibitors in patients with diabetic nephropathy. Okay, because they delay or prevent this diabetic nephropathy. Non-diabetic nephropathy, they reduce proteinuria by decreasing the pressure gradient across the glomerular capillaries as well as by altering the membrane permeability. Next use in scleroderma crisis, the marked rise in blood pressure and deterioration of renal function in scleroderma crisis is mediated by the angiotensin 2. So when we use ACE inhibitors, this angiotensin 2 will not be produced. So this crisis will not happen. Next class is angiotensin receptor blockers. These block the receptors on which angiotensin 2 acts. They directly block the receptor on which angiotensin 2 acts. They are also called angiotensin 2 antagonists. They are the losartan, candesartan, valsartan, irbesartan, olmesartan. Their pharmacological effects of ARBs are similar to those of ACE inhibitors. ARBs produce both arteriolar and venous dilation and block the aldosterone secretion, thus lowering the blood pressure and decreasing the salt and water retention. But note that they do not increase the bradykinin level, because in ACE inhibitors, when ACE enzyme is inhibited, there is accumulation of bradykinin. But you are not concerned here with ARBs. You are not concerned with ACE enzyme. It is acting on the receptor. So the pathway of bradykinin will be spared. There will be no accumulation of bradykinin. So with the cough with ACE inhibitor, with ARBs, cough is not the problem. Or if there is a cough, it is very rare. So you may be asked why cough is not the problem with ARBs and why it is the problem with ACE inhibitors. So you will tell that with ARBs do not increase the bradykinin levels. They only block the receptors where angiotensin 2 acts. So cough is not the problem. So they are maybe used as first line agents for the treatment of hypertension, especially in the patients with compelling indication of diabetes, heart failure, and chronic kidney. Next class is direct renin inhibitors. I have told you that the renin break down the angiotensinogen to angiotensin 1, and then this angiotensin 1 is broken down by the ACE into angiotensin 2. So the first step is blocked by renin inhibitors. If you use renin inhibitors, there will be no breakdown of angiotensinogen to angiotensin 1. There will be no angiotensin 1, there will be no angiotensin 2, there will be no vasoconstriction, there will be no rise in the blood pressure. So these renin inhibitors basically block the enzyme renin. And the drug name is elascarin. It directly inhibits the renin, and that acts earlier in the renin angiotensin aldosterone system. So it acts on the first step. It lowers the blood pressure about as effectively as ARBs or ACE inhibitors and thiazides. And these elascarin is usually not combined with ACE inhibitors or ARBs. Elascarin can cause diarrhea, especially at higher doses, and can also cause cough and angioedema, but probably less often than ACE inhibitors. And elascarin is contraindicated during pregnancy. These were the drugs that act on renin angiotensin aldosterone system. On first step, renin inhibitors act. On second step, ACE inhibitor acts. And on third step, ARBs are angiotensin receptor blockers act. And how they decrease the blood pressure, I have told you very clearly.